Ladies and gentlemen, boys and girls, buckle your seatbelts for today's epic clinical roundtable. Between all of us here today, we have more three-letter acronyms after our names than Daenerys Stormborn Targaryen has titles. We're live at Gotham Podcast Studio in New York, sponsored by nobody. Introducing first, sitting across from me, this man is from the great state of New Jersey, a New York licensed doctor of physical therapy, graduating from Columbia University, newly board-certified orthopedic clinical specialist, managing a busy outpatient ortho practice in Manhattan. He has a black belt in Taekwondo and a passion for teaching pain science. His first time on A Few Good Physios, Dr. Jordan Seda. Thank you very much.
Thank you. It's a true honor to be here, and looking forward to getting this going.
Thanks, man. And introducing, also across from me, returning guest, sitting right across from me. This man hails from the strongest state in the country, Rhode Island. A New York licensed physical therapy assistant working with professional athletes, travels across the U.S. to deliver the most up-to-date clinical evidence in conservative management, a former baseball athlete, current badass, holds the record for the best radio voice ever. And his episode on A Few Good Physios held the most downloaded for 3 consecutive weeks. Welcome back to the show, Mr. Matt Laliberte.
Thank you, Matt.
I'm pumped. This is awesome.
All right, so those are the introductions. If you guys want to fill in anything, please, anything that I missed.
Hard to beat that, brother.
Yeah, it looks like you read my biography there.
Yeah,
Thanks for buying the book.
Yeah, man. My pleasure.
So how do we get started? I think
I didn't get the show notes out.
Yeah, we'll get the show notes out, but I think we've been waiting for this for a while, and this is the first time we've had 2 guests. So I don't know. Where are you going to start? Somewhere in the middle? We'll start with the latest and greatest topics. We threw around a lot of topics, and Jordan and Matt kind of responded. I think we should start with some of, I guess, the clinical challenges that we face. What do you think, Lee, man?
Yeah, that sounds good. Yeah, I think one of the biggest things, let's see, in the challenges that we face as providers, how about talking about insurance a little bit, since that was our last podcast that we did?
Yeah, it was pretty, just listening it to today for the second time, it was pretty heated, and it definitely shows a clear delineation of practices that accept insurance versus practice that don't accept insurance. So I guess we could start off with Jordan with, you came out of school working into a practice that accepts insurance, and what's your experience?
Yeah, it's interesting because, coming out of school, the practice that, I started at and I currently work at, I really thought was, the most optimal setting for me coming out. 30-minute treatments. I felt like I had a good group of knowledgeable providers surrounding me. It's like, oh man, this is going to be great. Here I am 3 and so years later, and in many ways it's still very good, and I am able to provide a very high quality of service to the patients, regardless of all the insurance challenges, which of course are daunting, and day to day it doesn't get any easier to provide that quality of care. But yeah, just trying to stay motivated and trying to get people better, in less time.
Don't do it. Do not do it.
I was going to do it.
No, it's all right. It's
awesome.
It's a brand. That's great. Trying to get people better. Period.
Yeah, that's it. Get them out of the clinic.
Yeah, get them out of the clinic. No, and Matt, we have Matt, someone on the other side of the spectrum right now. And do you guys accept any insurance?
So we're exclusively out of network or cash pay. Most of the cash pay is going to be like the pro athlete. But again, like we're pretty much out of network, and we're pretty selective with them too. We've just kind of found that, and by we, I mean like the people who are in charge of me. Have kind of just found, like, because of the overheads in New York and because of the just rent cost, utility cost, that sort of thing, it's just not feasible to be able to deliver the type of one-on-one care we want, without having to have like 15 people in the clinic to one PT or PTA and still be able to do the things we do. You just can't keep the lights on, really. So like
That's right.
Yeah, so we kind of, I feel awful saying it, but like it is a little selective based on the insurance plan that they have and the insurance carrier that they have, which is miserable. But we do a good job of taking on people who don't have insurance that we would normally take, and we're able to subsidize that based on other people, coming in.
No, I think that's selective. I mean, I do that myself. As sad as it is, right? Because you do want to help. I mean, we all got into this profession to help. But like you just said, I mean, to keep the lights on and to feed my family, I can't sustain without being selective. But yep, it's New York City.
And I was also like the fact that the having that sustainability is what's gonna make you a better clinician. So you're gonna be able to take more con ed. You're gonna be able to practice the way you can to help people. And I feel like that's one of the biggest limitations with insurance, where they're kind of trying to back you into this corner where you can only do a certain amount of time with the person or a certain amount of services, whatever it is. And then doing this other way, out of network or cash, you have a lot more freedom to implement these treatments that can really help the person.
Yeah. As we mentioned last week, that being said, people do expect more if they're paying out of pocket, or they're paying, out of pocket, or they see what their out of network cost is. And that tends to self-select people as well. Aside from them having the resources to get there in the first place, they're literally bought into it. So they have skin in the game, so to speak, in terms of, they're putting out some money. So I find that in some cases they're much more motivated. In some cases, that being said, I've met countless people in the in-network scene that they were also motivated. But again, there was a lot of restrictions and frustrations.
I gotta tell you, I get that, but I kind of like the idea of someone telling me, or not telling me, but the patient knowing, okay, I've only got 25 visits to get better, right? So, I have to take this seriously. Every time I come in, I have to be at my 100% on my game, right? I can't come just in dilly-dally, I'm not feeling it today, No, you have
I don't
X
want to
amount
do
of
the
visits.
exercises. Can you just work on my shoulder?
Exactly. That's exactly it. And so we do find, and I especially see it in my practice, some people come in, can we just do a bit of light stretching today? I had a really busy meeting, and I just don't feel like doing it. And
So why are you here?
Yeah, so why are you here? At that point you start to wonder, are they coming in because of the ritual of it? And then okay, so I know we're not doing pain science this episode, but
No, we're doing anything.
We're doing everything.
I'm ready for it.
Yeah.
but yeah, are you coming in just for the ritual of coming in? Are you coming in because this is a social environment for you, or are you coming in because you actually have a problem? And that's kind of where and it kind of ties into the burnout, because you end up seeing a lot of people who are just here as a social experience.
Right. That is a very taxing, because you vibe. Your hands are on that person. You're in that vicinity of the person. It's infectious. This. How does it feel? The same.
Yep.
Had a bad day.
Yeah. It's I get it, but I also have people who actually need rehab. So let's why don't you just go to the gym and make some friends?
Right. Right. Just go out for a drink.
Yeah, exactly. Go eat some good food. Yeah. It'll make you feel good.
Walk.
Yeah.
Go talk to some people.
Yeah.
I mean, initially, I totally see your point, and who doesn't love some good food? But I think it's a difficult thing when someone comes into the clinic and they're kind of either apprehensive about doing some sort of being an active participant in the treatment, or they had a stressful day at work and they don't want to do anything. I hate. I'm going right into the pain science because that's my thing.
Yes.
But you kind of have to meet them halfway and be validate why they're feeling the way that they're feeling. Hey, I understand that you had a stressful day at work, but I think the only way for you to really be in control of your symptoms, and actually, I'm trying not to say they get better, whatever, but to really, expedite your recovery is to, load the crap out of your problem. So, you got to find a way to be okay, you're meeting them halfway, and then they're doing some exercises better than just, getting some muscles rubbed and maybe some Theragun or Hypervolt or whatever is popular nowadays. But yeah, I think that's definitely part of it.
No, it's an art. It's an art to take, some of our, my most challenging patients have taught me the most and taught me in the sense, the art of, listening about the day, validating the day and saying, okay, why are you here? Let's, and
That's fair.
let's get to the meat and potatoes of what, but again, it's an art, and each patient, client needs to be approached slightly different.
And I do agree with you where, like, I'd rather have some limitations, but to the extent of, I think they've kind of gone over on one end where it gets to the other extreme of behaviors where people are like, well, I'm just going to come in because this is what my insurance, I have this benefit and this is free. Like, I had this person the other day who reached out and we were going back and forth, and I was away for about a week, and so I had an out-of-office reply, and they went somewhere else. But basically, in the email, it said, it was hilarious, and I tried to explain what we can offer and things like that, and what we would be cash and out of network. And the guy's like, well, that's all great, but out of convenience, I went close to my work, and I satisfied all my in-network stuff for the year, so it's just basically free. And this person literally is a martial arts athlete and had a pretty serious surgery, all these other things. I don't know where they're going to get service from, where they're going to get treatment from. But that's another mindset, I think, when there's too many limitations on, then you get these other behaviors like, well, it's owed to me. Like we talked about a little bit, I think, one of our first podcasts. And
like an entitlement, like
I'm paying for this
hopefully
monthly.
You don't have to use, physical therapy. You shouldn't just lie on a table just because I'm paying $800 a month for my health care.
Right.
I got 30 visits. What do you got for me?
I'm going to do all 30.
Yeah. So ultrasound, e-stent, whatever it is. But it's what we're dealing with.
Yeah, and I think so. With that, there has to be some sort of joining together of the two. So some limitations, but also the really good education about what high value care is. What their responsibility is as a patient, and then our responsibility as a clinician to provide that. So, kind of right in the middle.
All challenges.
I mean, so I actually have a question for you guys, kind of like based on that guideline, and it's something I've been fighting with for a little while. And Jay, you might be able to give some insight on this, because you haven't been practicing as long as these guys, right?
Not even close.
No.
Yeah, they're like the grandfathers of physical therapy.
Old.
I'm drinking tea for God's sake.
Yeah.
This is like
Kombucha.
happy for me.
Oh my god,
Kombucha.
you guys are like AARP eligible, right? When we get out of here, you guys want to buy me lunch? You get 10%.
Oh man, that's hilarious.
But so like with all this, like, all this patient education stuff and like a lot of this pain science stuff coming out and that sort of thing, we know how important it is to talk to people, especially when you're trying to get them healthy, whatever that means, in the number of visits that they have, right? Okay. Is it frustrating for you that it's you could just talk to them and like that can help get them better, and then like okay, so when I got into PT, I was like, I am going to use my hands. I'm going to break up every ounce of scar tissue you've got.
Right.
We are going to stretch the hell out of it. You are going to be walking here like Gumby, and then you are going to get strong, and you're going to be like an Olympic gymnast.
Mm-hmm.
Everyone. And now I'm just like, I get it. Like, you need to just, like, get it together, figure your life out, de-stress, right? Lift something heavy.
Take a nap.
And you'd be all right.
Drink a little water. Yeah, it is frustrating. I think I find myself in the ritual sometimes of having that discussion, potentially getting someone on a treatment table and going through a ritualistic releasing of sorts. And it's what the patient, an expectation the patient has, is somewhat of an expectation of my other brain, another part of my brain that says, well, we have to go through this. And it is frustrating, especially if you've been seeing the patient for a while. And yeah, it's a tricky thing, it is frustrating. But at the end of the day, there's a certain key elements of the session, I guess, that help me validate or kind of rationalize what I'm doing. Like, all right, neural input. All right, I'm giving this person a little more confidence. All right, this person is objectively making changes. This person is reporting increase of their recreational activity. But it is. I would say it's frustrating for me, for sure. I mean, it's. You have to question even what we're doing with our hands, right? I mean, that's the whole pain science thing in a nutshell. But
yeah, 100% frustrating. I feel like I've been reflecting on it a lot. I think I mentioned in one of the podcasts that we had. I don't remember which one now. It wasn't the insurance one, but I view manual therapy as like negotiating with the nervous system. So sometimes with either education conversation can't achieve a change in the person's nervous system, sometimes they would need a little manual input, and it could be, neuromodulation or soft tissue work or just traction, whatever it may be. But the education is key to sprinkle in there. And the frustrating part for me is I find so much more comfort in doing something that I have a little bit of answers for, in a sense that manual therapy, when we learned in school, we learned in initial Con Ed courses that we took, there was an A plus B equals C scenario. Now with pain science, there's this
doesn't follow a linear path.
Interstellar, Inception, manual. There's so much stuff, and everybody's very complex in that sense. So then now we're having to incorporate, how much do you sleep? How, what's going on? Do you have a trauma in your life and all this other stuff? So
yeah,
it's really interesting.
To build on what Lee's saying with the pain science, it would be a lot of people would benefit from the conversation, but there's definitely a part of, there's definitely a demographic that conversation's okay, so what am I here? What are you going to do? That's cool and all. They have a kind of an auditory block to some extent, and if you throw in the kinesthetic, the feel of it, it's oh, wait a minute, I feel that different. Visually, let's say a visual thing where they're what is this guy saying? My arm still doesn't move. I can't move it. So, I mean, I guess addressing, we've learned about the learning styles of people and how we're a blend of all, but some people just will not take that story well. As you all, I mean, we've all had that experience of this, so it's in my head, and so I think what Lee said is correct. I mean, having some kind of something tangible, although maybe not working for the reasons that we were taught, it's another tool.
Right.
It's another tool.
Yeah, and even David Butler, and if you guys don't know who David Butler is, he's a really prominent, neurophysiologist out in Australia. He wrote, series of amazing books, most recently Explain Pain Supercharged.
Got to see that. I haven't read that one. Good.
But even he created this whole system on how to approach, patients with all of these contributing factors to their symptoms that even his brother-in-law, I believe, he tried to counsel him on pain science, and his brother-in-law was not having it whatsoever. So he's you know what? I'm just going to send you to the best manual therapist I know. He had a couple manipulations, mobilizations, and his brother-in-law felt fine. So even he, the guy who created this whole system, acknowledges that there are some people that are just unwilling to hear your message. And even if they're unwilling to hear it now, maybe they'll be okay, this guy's full of crap. And then maybe a year later, they're not out of pain yet and they're having difficulties. They'll come back to you a year later and say, you know what, I'm ready to listen to what you have to say. So, some people are ready. Some people want the pain science information doused on them. Some people need it sprinkled. I think that the challenge for the provider, but I think the most competent and most successful providers are the ones that understand, which patient needs which particular information and deliver it at which and with which communication style at which given time. And it is incredibly complicated. I never thought that physical therapy would involve so much, pain science and dealing with all the other factors in people's lives, but it certainly does. And if people are undermining it in the clinic, you're really doing your patients a disservice.
Yeah, I mean, there's some of it, I don't want to say it's common sense, but it is common sense human interaction. You're telling them the story and their body's just closing up and they're pulling away from you and they're looking down and they're shaking their head. All of these signs that you should just stop. Change your direction. I mean, and this is within the pain science, but there are others that are not speaking pain science and maybe using threatening language.
I'm sorry, I don't mean to laugh. But we've talked about some.
Yeah, we've talked about therapists that threaten their patients. And that's the other side of it. You know, it's crazy.
Right.
No, it's not Lee, but he's looking at Lee like, are you choking your
I'm not-
patients?
no.
You're gonna get better. You're getting an arm bar.
I'm going to get that right. I'm going to get your range of motion back. But it is an art, and I think the most successful therapists do know when to use what, whether it's pain science or a little clinical tools. But that comes down to, I think, some just basic communication skills. That it's tough to teach, but it is a teachable skill. I do think it's a teachable skill.
I think that we had a course in school education.
Yes.
Where there were multiple sections of it.
Yeah.
And-
Well, yeah.
And they what they were trying to do, and I'm sure you guys had this too in school, were basically a communication to the patient, being able to observe like cultural differences, being able to observe different psychological barriers, and then being able to effectively communicate and teach this person. And Eric and I found it very, very helpful. It wasn't really well received with the majority of our class, I think, because I think they saw it as some sort of, it wasn't very clinical in a sense that, anatomy, physiology, biomechanics, all that stuff. So, but I feel like there has to be more of that with the use of pain science information, so they can change language or at least alter the language that they're using with patients, and that will be kind of like a key component to education along with strength conditioning.
Yeah.
But
Yeah, no, it's basically kind of categorizing a person's learning style, number one. Understanding your own learning style, that's another thing as a clinician. I mean,
right,
what
yeah.
works for you best? If you got to be comfortable with, I think a lot of our graduate school is kind of delving into a lot of self-reflection. And then that should stick with you until, that should be a continuous process. But that self-reflection helps you deliver your message. And you know your strengths, you know your weaknesses, but most importantly, understanding the patient across from you, critical. So I think in med schools, they're changing a lot of the curriculum to include this bedside manner. And the post we did recently with I think in the UK, they're changing the use of medical jargon with patients.
Did you guys see that in the Times? Yeah. But that was very interesting.
Pretty cool stuff. So, I mean, the message is...
It's not going to be in the show notes.
It's not, yeah. No.
You can just look it up on
look
Instagram.
it up. New York Times.
Google it.
Yeah, Google it. But
The Brits.
in school, that they go in like education, that they go into like learning styles or delivery of messages and...
It's interesting. I actually, from my experience, I went to Columbia, so I have the best education money can buy. So I know more about this than anybody at this table.
Right.
So we did have,
He's paid a pretty penny, I'm sure.
Bestow your wisdom, please.
And we did talk about, what we call the biopsychosocial model, which, I know the guys on the show have probably gone over this before, but, how personal and environmental factors, contribute to somebody's symptoms. And, we would talk about it, and we might break off into different groups. But interestingly enough, my research at Columbia was actually not on all the fancy stuff like biomechanics and how to objectively measure something. It was about psychosocial education. Mm-hmm. And we actually looked about, just like on a continuum throughout the country, like what are common themes that are being taught from, PT school to PT school? How much emphasis is there based off of like credit hours and stuff like that? And it's just very interesting that it's just, the terminology is all over the place, and, how the classes are structured all over the place. And in our research, actually, we did look a lot into like medical and nursing, because the PT literature in terms of teaching this content is quite poor. I mean, there's a lot that talk about like identifying yellow flags and all that stuff, particularly in response to low back pain. But the best way to do it, based off of what we saw, is just to get small groups together. A lot of medical schools hire paid actors to portray a patient, and they get like maybe 4 or 5 students with either an adjunct professor or a senior clinician, and then they take turns communicating with the patient. They found that to be particularly effective because you get there's like this, they coined it, I forgot this one article, a 360 feedback loop in terms of like peers providing feedback to their peers, the actor providing feedback to the student, and then the professor providing feedback to the student. So you're getting multiple levels of feedback, so you can really, appreciate the experience, dealing with an individual who, is in dire need of services and may have a lot of things going on. So, it wasn't to that degree at Columbia, so I want my money back. Columbia gave me my money back. But actually,
that's a great. I mean, we've been Lee and I have been part of that at our school we went to in Turo. We were and I what you just said is key. Like I was a patient actor, and it was a tough process. You have to kind of fit into the role and kind of feel what this person was feeling and walk the way this person would walk and respond like the hundreds of people you heard. And, it gives you a different perspective being a patient and then getting the feedback from the student. What you just said, I mean, I witnessed, we've been part of that. And it was fun for us. It was definitely helpful for the students had a good experience. But you're right, though. I mean, even this education class that we took, it wasn't really considered too serious. And I mean, I saw the power in it because they went over. I mean, one of our projects was like creating a presentation and like having a template for any presentation. I still use that to this day, whether it's a PowerPoint presentation or it's an introduction to a new patient. It's like that little format. And again, I say kids, a lot of my students, they didn't see the value, unfortunately, because they didn't really have much work experience.
Yeah.
So they wouldn't see the value of it. But that's really cool that you did research on that.
Yeah, I mean, I value that, patient-provider interaction from day one. That is one of the main driving factors, aside from the fact that I got hurt in high school and that stimulated this whole, pursuit of physical therapy, like 90% of the applicants to PT school.
Right.
But, really getting to know people on a more profound level than, the typical. And I'm not saying that all physicians don't get to know their patients, but we see patients very regularly. We get to know a lot about them, and they open up to us. And, I value that time. I value that every patient has a story, and a lot of people just aren't being listened to maybe in their personal lives. From other providers, they're just getting passed along the healthcare system because maybe nobody wants to deal with them. So I really think as long as you demonstrate just a baseline level of empathy, like appreciating where this person has come from, that's here to see you for services, and at the very least you're going to provide an average level of pain science education, and then you could supplement that with your clinical skills. Not to say that you have to be the best at addressing pain science, but you're going to provide someone with pretty much a groundbreaking treatment that they're going to be like, whoa, I didn't know physical therapy was like this at all, and you're going to really turn some heads.
That's good stuff. Matt, did you have any experience with in school, when you went to school, that they emphasize delivery of message, of communication at all?
So I went to the not greatest school on the planet,
No.
which is everyone but Columbia.
Where is it?
So I went to the City University of New York. So I did my PTA through CUNY, and we actually had like a whole class dedicated to us pretending to be patients for our fellow classmates, which is, in theory, a good idea. In practice, awful.
Well, that's true. As a student, it was horrible.
Yeah.
We couldn't.
We were like the worst patients in the world. We were like, we were just making weird shit up.
Yeah, like I walked in there. I think one day I came in and I was like a patient with like a quote unquote frozen shoulder. Definitely made myself a fall risk. Like there's no sensibility to it. There's also like you don't get the realness of it. But we did get that sort of education, and then we also had to do like a final like senior project sort of thing. Not quite like a senior thesis that you get at the doctoral level, but like a similar project. And we had to present it at whatever our last affiliation was. We had to the objective was to try to change something that they're doing to try to make them a more effective clinic. And so what I went in and talked about was something kind of similar, and it's very pain sciencey. We're talking about like imaging and how like if someone comes in with a bulging disc, like okay, good for you, you walked on 2 feet, great. Like that's probably not the source of your back pain, but like but then we started talking about, but then the presentation goes on and it talks about well how powerful are we really in talking to people about this, right? Like we are most likely the 5th person or 6th person to see them and talk to them about this issue. Mm-hmm. So they've already got 5 or 6 people telling them like this is what's wrong with you. So yeah, we're nothing. Like in the grand scheme of things, like it's by the time they get to us, it's not. So, what one study? I'll see if I can pull it up on my phone or something. But one study, they made a pamphlet, right? And they made 2 educational pamphlets. One was for chronic low back pain. One was like, this is what back pain is, and like that's pretty much it. Like it broke down like what the words back pain mean. And then the other pamphlet was like, it had bright colors, very educational, very comforting, told you like, this is, you could get better. These are the things that can help you. This is kind of what it comes from, and this is how you get better. And they found that the people who had like the more educational pamphlet, their fear avoidance beliefs, which is like the thought you have that whatever is in your mind endangering you is endangering you. Like the realness of that. That's your fear avoidance beliefs. So,
Do you remember which one they used? They used the Tampa or Maine ones.
I can't remember.
Okay,
this is a long time ago. I'm also old, and by old I mean 27. But they found the fear avoidance beliefs and actually pain. Their 0 to 10 VAS pain rating.
Oh, that's great.
I just like to look at his
Horrible
face.
smiley.
No one can see what my face looks like. That was a hard eye roll. That was like 14-year-old teenage girl being sent to her room. Eye roll.
VAS.
But their VAS was significantly lower in the people who had gotten the good pamphlet. And so I kind of I finished my presentation in front of all these people, and I was just like, the last thing I gave them was, you are more powerful than a pamphlet. Standing O. Like
Nice.
mic drop, there it is. Like the president in Independence Day, the original one, I've never saw the new one, but Independence Day gives this is our that was it. That was the one.
That's awesome.
But like when we kind of talk about that, like, and one of these articles actually that Jay had sent over. Do you guys want to introduce the articles before we talk about them, or?
Yeah, you can go for it. Which one? This is the burnout stuff?
Yeah, this is the burnout stuff. So
This will be in the show notes, everybody.
praise be. So this one is burnout syndrome in physical therapists, demographic and organizational factors. Does anyone want to give these names a shot? On the
Are they
authors?
Swedish?
They're Polish.
Oh.
I think
Yes.
Lee knows a little Polish.
Yep. I'm not gonna even try. I'll probably insult a lot of people.
Yeah, they're a really great group from the University School of Physical Education, Academia, Wycomia, in Poland.
One of them looks like one of UFC fighters.
You want to give it a shot?
Karolowskis. No.
L. I could read the L.
L. Zidzau Karolowskis.
I can't even tell where you are on the page.
All right.
They'll
sorry.
be posted.
We love Poland.
Yeah,
They're posted.
really good paper. Thank you, authors, for writing it. So one of them actually, I want to say it's in the introduction. They talk about how something Jordan has said before, how PT patient contact is so much different than doctor and nurse's contact, and so like. Doctors and nurses, my mom's a nurse. Like, I totally get it. I've seen her emotional investment over like the 27 years of my life with her patients.
Wow.
And it's there, it's heavy, but she has a cycle of people. You know what I mean? Like, people come in and out. Doctors, again, they come in and out, or they see them on, like, if they see a regular patient, it's on, like, every 8 weeks max?
Yeah.
Like, and even that is a stretch.
This is in a hospital setting?
Yeah.
Or, yeah.
Well, this is in general. I mean, like, I can't remember what the number is on it. I don't know if anyone knows, but
The average.
yeah, time between doctor's visits for the same practitioner. We can find that somewhere.
Yeah.
But for PTs, it's much more regular. If you're seeing someone for 8 weeks, it's twice a week for 8 weeks.
Right.
You know what I mean? So you're seeing them pretty
16
regularly.
hours, 8, let's say 8 to 16 hours, they're going to see you.
Yeah,
That's a lot of time.
that's you're meeting someone at that point. Like that's like 7 or 8 dates in.
Yeah.
Right.
It's true. That's a great way to look at it too.
Yeah, And
Relationships.
that's right. You build a relationship with these people, but like Jordan was saying, like it's a powerful tool that you have, but it's very taxing. And this first paper kind of goes on to talk about like. The reason why we need to, I think, look at burnout in physios is because of this connection that we build with our patients, and because we get so like pain sciencey and try to be, so empathetic and understanding of what our patient is going through. it does take a toll on us, and that's a lot of weight for us to bear. And I mean, don't get me wrong, like I love to take a nap and eat good food and lift heavy loads, but like
at some point you need a vacation.
But at some point you have to do something for yourself, and so like maybe we need some physical therapy. That's what we need.
Yeah, man.
Lee and I discussed this at length. I think in order to be effective at what we're doing, there has to be a lot of me time. I mean, it sounds a little selfish, but self-preservation. I mean, you gotta take care of yourself first before you can take care of anyone else.
I have a great analogy. I was just on an airplane.
Yeah.
What happens when the oxygen comes down and you're with a small child?
Put your mask on first.
Yeah,
exactly.
You gotta take care of yourself first.
It's the truth.
Or else you're gonna be dead, and that person's not gonna be able to help themselves.
But that's the way it goes with burnout, though. I mean, I've witnessed this. I've been part of it. I remember working to the ground, and I was much less effective. And just when you step back and take care of yourself a little better. But yeah, that relationship, we have a unique. I mean, it's a blessing and a curse, right? I mean, the blessing is you have all this time to drive a message to the person that initially they may not receive due to barriers, whether that's pain, whether that's
units,
whether it's authorization.
Sorry.
But yeah, you're right. After 7 dates in, and you really don't want to be on that date, it could be tricky.
I was trying to tell someone in my family what PT is like because they had no idea. And so I was trying to make the date analogy. And I was like, not only do you have to get them to let them kind of feel to come back for a second date or a third date, but you need to like also extract information from them.
Yeah, a little interrogation.
Yeah, you have to be like an attorney. You have to be an accountant. You have to be.
What's your best method? Your waterboard or?
Well, Matt said earlier, I just say like, if you don't tell me this information, it's going to be an armbar.
I'm going to choke you. Oh man. No, it's an interest. That's a pretty cool article. This was in Poland, so that's sad that Polish therapists are
now.
out.
When you guys looked this up, Jordan, you did a lit review for burnout stuff.
Yes.
Did you see anything in the United States done in the United States?
Yeah, there was stuff done, but not really for physical therapists. It was mainly for medicine and nursing.
It's amazing. This is the third time I've seen this when done a lit review on burnout. It's usually from overseas.
I think PTs by nature. I mean, are good copers. No, natural. I mean,
I have a good article about coping.
that coping, right? I mean, PTs in general. I mean, they typically cope well with stuff. But I witnessed. I mean, I had an incident with a family member last week where he had to go to the ER. Full disclosure, my brother choked on a piece of steak, and he calls me like, "Hey,
it sounded like it was something serious."
No.
I was like, "Oh my God, are you all right?
Yeah.
Do you need me to console you? Your brother's choking on steak."
He's choking on steak. He calls me like an hour into it, and he's like, I can't stop throwing up." And I was like, "What?" I was choking on a piece of steak. I gagged myself. I don't know what, and he's
Rich, I thought it was serious. He was texting me the whole time. I thought it was serious.
And I was like, go to the hospital. I'm like, go. No, it's funny now. I was like, go to the hospital. He goes, no, I think I'm all right. It's not as bad. Then he texts me the name of the hospital. And I rush over there 40 minutes later. He's with his son. And I just walk into this place in the Bronx, right? It's a small little community hospital. It's like a war zone. People are choking. There's blood. And my brother's just gagging, And he's gagging every 2 minutes. But I looked around and, like, everybody looked stressed out. The doctors didn't lift their heads. The nurses were doing most of the work. Even, like, like a non-medical professional was taking information about insurance while my brother was throwing up. They were asking him, hey, and she was very polite. I have to say, across the board, the security guard, everybody was very polite, and I was trying to be as polite as I can to get as much help. Anyway, moral of the story is, I mean, just looking at all the healthcare providers, they looked exhausted. Luckily my brother dodged a bullet. He got a CAT scan, and he they were going to give him an endoscope, and he was like, he was like, I got to get out of here. Give me a cup of water. And then the nurse was like, no, you're going to another hospital. So my brother got up, he drank water, gagged, and then he was like, I feel better. So 10 minutes goes by, he doesn't throw up. the nurse was like, "Is he all right?" And he was like, "I'm ready. Please get the IV out." He's on IV. And it was pretty serious up until then. He was like, "I can't. I don't want to do an endoscope. I mean, I'm not choking." So the doctor came over. He lucked out. He didn't get the endoscope. But moral of the story is these doctors were they were burnt out. You could tell, and everybody and I could understand. You got patients talking about coverage on our way out of the hospital with 3 security guards around this little booth. The security guard was like, "Oh, if you're going to get discharged, go there." And the woman looked at him, and he has health insurance, luckily. And she was like, "There's a copayment." And like my brother was like, "Okay, what is it?" He's like, $250. And it was like this quiet moment, and my brother was like, "Okay, here you go." And she was like, "You want to pay it all now?" And he's like,
She was preparing for the worst.
she was preparing for the worst and then I thought to myself, I'm like, "Oh, that's why they have security here." Because people must get to the thing. And for someone, now the CAT scan alone must have been about $1,500. He'd got an X-ray. A saline pouch probably was $400. The nurse, all of these, it probably, he hasn't gotten the bill, but it was probably like a $4,000 bill. But going into healthcare providers that are burnt out, community hospital, dealing with many individuals that don't have insurance. This is actually the doctor's office. So sorry for the tangent, but
we love tangents.
just an example of the stress. And again, I'm very thankful, as Lee and I discussed, that if we didn't have this care, who knows? He could have still been choking on the steak.
Yeah, it was funny when it wasn't funny, but when Eric was texting me this stuff, and we were both trying to figure out what's happening.
Dr. House.
Yeah, we started to get a little housey, and I was like, how about he put some vinegar down, like apple cider vinegar down his throat, and see if it digests the meat.
That's what my brother was like. It's been there for 4 hours. Don't you think the enzyme? I was like, no, that's with bread, bro. You need to, if it's a piece of steak, you need acid, man. You need. He was like, and I was like, "You want to try vinegar?" And I asked the nurse. I was like, "You think it?" And the nurse.
She was probably like, "What the?"
The nurse looked and was like, "No, man, take it easy. We don't have vinegar." He was like, "We don't have vinegar. He's gonna need an endoscope."
We have real medicine.
Do some jumping jacks. Just get it down there.
Oh, it's crazy.
Just
They
load it.
They put an IV on. I was like, "Why are you using an IV?" He was like, "He has to be dehydrated. He's been throwing up for 4 hours." I was like, "All right." And he was like, "Are you nauseous? Are you not?" And he's filling up a syringe. He was like, "We're going to give you anti-nausea medication." My brother's like, "I'm not nauseous. I have steak in my chest." Right? And he was like, "You sure you're not nauseous?" And with a needle, and I was like, "I don't think he needs a nausea medication. No, it's not."
So they need a special test for steak joking.
I don't know what the ICD-10 is on that.
Dude, ICD-10 codes.
Oh, they got shark bites.
They got boat accidents with the left arm versus the right
Thunderclap
foot.
headache.
Thunderclap.
Thunderclap. That's the Hulk, isn't it?
Yeah.
You don't
I
want to
see
meet
Jordan
him.
looking at his thing. Talk to us about that article.
No, I love tangents. If you guys want to keep going.
No. I want to stay on task. I want to stay.
I want some steak, though.
No,
right?
Chew your steak. Oh, that's another moral. Chew your steak.
Yes.
Take your time.
That's
Don't
interesting.
stress.
I actually just looked at my notes. There's an ICD-10 code for a burnout syndrome.
Really?
Wow.
Z73.0.
Z codes.
That's like that's a
A surgical code.
surgical code.
Yeah.
Well, give that to every therapist that we know.
Yeah. I mean,
How many visits get approved for that?
60.
Yeah.
You get 2-week vacation.
yeah, in which context to use that, I have no idea. But I
burnout
found that
syndrome.
interesting. I found it interesting because it must be more common than people think. And I
Yeah.
think that's the point we're trying to emphasize here is that, we are all very well-intentioned providers, and I think that you don't go into physical therapy school unless you are well-intentioned and you want to do right by people.
Right.
It's just as we've been talking about all the insurance demands and just the number of people that are coming in and out of our clinics and the content in which they're sharing with us, it can bear us down. And it's not that we don't care because we want to hear all of your stories. This is all the patients out there who might be prospectively seeing us in the future. We care about you. We do want what's best for you.
Deeply.
But, it can become overbearing. And I think, it takes a lot for the individual to, process the information and handle it accordingly. And one of the pitfalls for me in my career, in the earlier part of my career, was that I was so kind of like how Matt was like, I'm going to get in there, use my hands, I'm going to affect change. Well, you know what? Change doesn't manifest that quickly, and sometimes it takes a while, especially if some people are in persistent chronic pain states. So if people aren't getting better, I used to just be like, it's me. I'm not doing a good enough job with manual therapy. I'm not prescribing the right exercise. Maybe they should do less repetitions. It didn't take me very long to realize that I was just hurting myself by thinking that way, and I started to realize, especially after taking all these pain courses, that it is so multifactorial, what goes into a patient's ability to recover. And if you internalize that, you're just going to end up setting yourself up for failure. You're going to add stress to your life. And not to mention, I'm sure, a lot of us have stressors outside of work.
Right.
And so why compound that with work-related stress that doesn't need to be there? And I think since I've been able to do that, I've actually fought burnout and have gotten even more inspired, despite all the facts with the insurance and utilization requirements. Like, I'm all in on my career, and I see a lot of providers out there, mostly young, but definitely some that are older that are like gung ho about the profession and trying to inspire change despite all of the negative aspects of the profession. So you really just have to find a way to cope, as we mentioned, and do something that makes you feel good. I think everybody needs to be happy. Everyone needs to laugh more. It's okay to share your thoughts with people, and I think if our patients begin to do that and they start to do things that make them happy, whether we are the ones to enable them to do so or not, everyone's going to end up better in the end.
Oh, for sure. And what you just said about kind of second-guessing yourself if a patient isn't getting better, it's common amongst all new therapists. I think if you care, you're going to have that feeling. But that feeling, the patients pick up on that very easily, whether the clinician is so wrapped up on their own thoughts that they forget that there's someone in front of them. And if you could just focus on the obvious things that you can implement change, whether that's pain science chat, whether that's kind of a gait training or giving them telling them what side to use a cane on, these little low-hanging fruit to kind of, one, to get buy-in, and two, just to kind of elicit a small change. But like you said, change doesn't happen overnight, especially in some of these chronic pain states. But what you just said, I mean, shifting one thing, we really don't understand how we impact our patients on both ends, right? But we play a big part in many people's lives, so it's pretty cool stuff.
With the pain science courses you've taken David Butler's,
Greg Lehman.
and Greg Lehman. So
Yeah.
I'd be interested to hear what was your thoughts on Greg Lehman? He's getting a lot of traction now, definitely in the United States,
And it's well deserved. He's a very well spoken individual, and so basically, if you don't know who Greg Lehman is, he's actually a physiotherapist and a chiropractor from our neighbors to the north. Not surprising, we have plenty of pioneers in the profession from the north, but we're not going to go into that because we can spend all day talking about that. But anyway, basically, the premise of the course is he builds off of all these themes that Peter O'Sullivan came up with, and David Butler, Lorimer Mosley, and all those guys, and he basically ties it into commonly thought beliefs about biomechanics. For example, like just the general spinal flexion intolerance thing is like, if you sit for a while, nucleus pulposus bulges back, and then tube and toothpaste, boom, it comes out.
Jelly donut.
Oh,
Yeah.
God.
Donuts.
They're everywhere.
Squirting all over.
But before he even went into any of the biomechanics, it was all about a paradigm shift in the patient. You guys might have talked about, the whole cup principle, about changing what's in your cup, either the size of the cup or the contents of the cup, and just generally reconceptualizing people's beliefs about movement and people's beliefs about pain. And before we even started, it's just like getting people to realize that there is more to their problems than a tissue injury. Now, certainly, they could have some sort of tissue injury, and from my courses with David Butler, it's just a matter of hypersensitivity at any local area that's in pain. But that's the brain's determined response for their pathology, not necessarily what's going on. But yeah, so he went on to talk about all these things about like we see all these biomechanical faults, like, dynamic knee valgus was a big one, or, serratus winging. If you see wings, you're like, oh, I don't even know if I could date a girl with serratus winging anymore after PT school.
I can't.
But the thing,
Shoot some wings.
I'm not in the market, by the way. Just throwing it out there. But yeah, so basically he was talking about, and there's one video that he showed that really stuck with me, and it was a really prominent physician, and he was doing a live demonstration looking at like scapular kinesis with movement and trying to attribute it to patient's pain. So he had the guy elevate both shoulders one at a time. I forgot which shoulder was the one that winged the most, but I think it was like the right shoulder. And then he tried symptom activity modification to see if it helped, because he saw scapular winging on the right shoulder, so he's like, okay, I'm going to address the right shoulder. And the patient goes to him and says, it's my left shoulder that hurts. So it just goes to show you that oftentimes, we see biomechanical dysfunction, and it's like, we need to fix it. Yeah. But there are plenty of successful athletes. There are plenty of successful athletes encompassing marathon runners, powerlifters. Like, they don't have martial artists. I should have known.
No. I'm sorry.
But totally valid. But just because someone has theoretical biomechanical flaws from this optimal alignment perspective, which I hope the profession is deviating from slightly, it's just a matter of if a biomechanical dysfunction is contributing to a patient's injury, it might be worth addressing. If it is not, you don't necessarily have to address it. Mm-hmm. And I think that's what, one of the key concepts from Greg Lehman is that, who's to say that for someone with patellofemoral pain, so patellofemoral pain is just a general term for anterior knee pain, for those of you who don't know what patellofemoral means. One of the gold standard, treatment approaches is hip abductor strengthening, like glute med strengthening, and then you see all these clinicians. I mean, you see some. I'm not going to say I can't generalize anything, but you see them doing all clamshell, sideline hip abduction, all these other things, but you still have to load the tissue that's causing the pain. And just because hip abductor strengthening has been shown to decrease anterior knee pain, it doesn't mean you have to do it if it's not contributing to their symptoms. Like, why can't you theoretically strengthen your hip flexors? Why can't you theoretically, work on...
Stand on one leg for a minute, right?
Yeah, I mean, there are... We kind of get zoned in PT school, and we learn about all these, biomechanical dysfunctions, and then we spend a whole course talking about just gait analysis and looking for deviations in that. And we don't necessarily have to address all those things, particularly if people are, moving in an improper, biomechanically inefficient way. You only address something if you need to. Otherwise, someone could be very strong going into dynamic knee valgus, and they might have no knee pain at all. And you could be doing them a disservice by correcting their, strong motor control into dynamic knee valgus.
Absolutely.
Yeah, I mean, speaking of just that in particular, it's kind of changed the paradigm. We've talked about FRC, Andrews being in here so many times. One of his... no, it's not. I'm sorry. Well, definitely FRC, Andrew Spina. He has his coaches who do this, but another individual, Ido Portel, who we also talked about, one of his main coaches out in Israel, I think he has to handle Roy Gold, or ROYE_Gold. He's a beast of a man, and his cover picture for his account is one of the most craziest things I've ever seen. So imagine like two, I think they got to be 18 inches box on either side of him. He jumps, and the way he lands is he has his feet on the boxes, and both of his knees collapse in, and he's almost pretty much parallel to the ground. So he's doing like full hip internal rotation, and he's just holding that position there. And so it's basically like an explosive valgus hold. And it goes against every biomechanical thing that you could ever say for the knee. And he's like one of the strongest persons I ever see do anything. But anyway, so like for that, I think those are key things. Like that's all information, like the gait, their movement patterns, that's all information. And I think that's where we have to be careful what we pass on to the patient in the sense of this is all good information, but in terms of how it relates to your quote injury and pain, it's not going to be, the cause of it. Us working with it is not going to be saying you're going to be in less pain because of it. We're just going to make you maybe more efficient movers, and or with the pain, it's going to be A, B, and C. So I mean, I feel like that's where overall I'm making a lot of generalizations, but I feel like that's where a lot of clinicians can get caught in the sense that like they don't know where to go.
It's hard because, I mean, look, the educational system is built on that biomechanical model. Patients, like as Matt just mentioned, you're the fifth or sixth person and they've been fed that. So, I mean, here you go saying, person saying, hey, it's this valgus on my knee. I mean, we got to fix this, I'm out of alignment. I mean, I probably hear it 3 to 5 times a week, out of alignment. And I try not to challenge that initially. Just let it simmer and figure out, all right, how am I was like, it's okay. Your knee's a little different from the other side, as everybody else is. It's okay. And it kind of start decreasing the threat of this malalignment. But no, it's great that there's so many young therapists with this amount of information where, we kind of found, we lucked out. We found out about things early, but we were kind of in the middle of the fence, and now I think things have definitely turned for the better, I think.
Yeah.
On this amount of information.
Matt, working with professional athletes, where does it I don't think we spoke about it too much last time we were here, but if you do encounter a patient who's really, at this point, being in a professional athlete, they must have already gone through a lot of physicians and other practitioners, and do they have already preconceived notions about alignment and posture and stuff like that? Do you usually have a conversation with, or you kind of like tease it out?
Yeah, so with the pro athlete, the way the treatment starts is it's kind of the same as it is with every person, like just trying to figure out what they think is wrong with them and what their understanding of the current situation is, right? Mm-hmm. And then understanding how uphill of a battle I have to fight from there. With these guys, a lot of times they just come in. Let's take baseball, for example, because I see mostly baseball. They'll come in and they'll just say, it is a pretty common one. We're seeing it more and more in pitchers now. They'll say, so I have a lot of tightness here and here. Oh, people can't see where I'm pointing. I have a lot of tightness on the inside of my arm and the inside of my forearm, right? So we kind of find in Major League Baseball that is a warning sign for a UCL injury.
Yes.
And which is a big deal.
Right.
UCL being like it's the ligament on the inside of your elbow that leads to like you can get Tommy John surgery afterwards, which I think actually Tommy John himself was in like an article recently saying I would not have that surgery.
No way.
Yeah, I saw it on ESPN.
Take my name off of it.
Yeah, which is not the most reliable source, but so a lot of these guys are having this discomfort. And we're looking at it from a perspective of like, okay, well, if you're throwing, you're an overhead thrower athlete, getting a lot of whipping at like your medial elbow. Well, if you have something else in your kinetic chain that's causing, this whipping, we're heavy on the fence about this. Like, we don't know if we should be treating. I mean, it's hard to say whether or not you treat the pro athlete differently than you do, your weekend warrior or like everyday athlete. Because the level of fine-tuning is different. Mm-hmm. We're talking about guys who have thrown a baseball. They've probably thrown on the scale of hundreds of millions of throws.
Wow.
Over the course of their life. It's just a lot of throws. And so the thing that they've done for their entire lives, usually we can get to the bottom of it somehow. So like it will be something acute that changed and then changed the habit for them. So what we'll do is we take video from like a year ago, we take video of right now, and we see if anything looks different.
Wow, that's cool. That's cool.
But we are like in this area where I'm saying to myself, like, if a kid just comes in and he's like, yeah, my back hurts and I've been playing basketball or whatever, that sort of thing, like I do have a very biopsychosocial approach to that kid. Like, I say to myself, okay, well, like, do you like school? Do you have friends? These sorts of things. Ask him, like, obviously in a nice way.
Do you have... My back hurts. What? Stop. Do you have friends?
Do you have friends? Do you like what they serve for lunch?
Do you like school?
Yeah. I mean, none of these kids do. They don't like school. They all have friends. But, like, I don't find myself asking, like, pro pitchers, like, hey, man, I heard you're going through a rough divorce. Do you want to talk about it? Oh man, I instantaneous flare up of his elbow.
My elbow's good, man. Thanks. I'm out of here.
We look at the video. We say, oh man, like, you know, if we look at his video from a year ago where he was throwing 102 and throwing consistent strikes, we look at his video for now where he's throwing 98, which I know doesn't sound like a big difference, but trying to hit a 98 mile per hour fastball versus a 102 mile per hour fastball is like night and day. You're closing your eyes and swinging at the second one. You look at it and like maybe his plant leg. So when you throw a baseball, you push off your back leg, you land on your front leg with a solid follow through. Okay, well he's got a significant amount of wobble on his stand leg now than he did before. If he can't land on that properly, now he has to change. He has to twist and change the way he's directing his torso. If he can't do that, he's trying to generate power from his arm and shoulder. That increases medial whipping at the elbow, and now everything in his medial compartment of his arm is hanging on for dear life. Eventually, that's going to get overworked and tired, and he's going to get a UCL injury.
So this is, I feel like this is like the perfect melding of what the biopsychosocial thing is. Like this is, I think for a pro athlete has to happen.
Right.
Because you're talking about cellular level stress. And,
repetitive stress.
Yeah. And if you start, that's where our expertise is as therapists, is we can break down movement and also assess joint play, strength, things like that. Then you can be like, here are the big components to look at a big picture. But the other side of that is, educating the person, saying like, we're not correlating this with quote pain, we're correlating this with possibility, a likelihood of injuring that tissue that it's not going to be that strong versus your hip, which is a little bit more robust, and we can kind of put more stress there versus your elbow.
Or optimizing performance, like 98 to 102, and being able to perform. Forget about your elbow hurts, but your elbow hurts because you're out of your efficiency zone, you know. Right. That's pretty cool. How that's fine tuning.
Yeah, I mean it's like we're actually implementing something really similar now with our patients in terms of trying to show them that the way they move is the way they move, and the way I move isn't the way you move, and that sort of thing.
Yes.
So for example, we do see a lot of like elite runners at the marathon level, and we actually just started seeing a couple 5Ks, and when they do like a single leg deadlift, right? Like one girl's got extreme knee valgus. One girl's got so much knee varus. I was like, I don't know how you walk, but good for you. You run at an insanely fast speed. She runs marathons faster than I could bike him probably.
Wow. Right. Oh man.
But yeah. So just watching them, then I think a doctor told the valgus knee girl, like, you got to get that sorted out. You're not gonna be running for very long. We do all this kind of run-specific strength and conditioning stuff that we've kind of developed, and she feels great. She's running 100% pain-free. This is the first time in years she has been able to run like this.
Wow.
And the sad thing is that she's run like 2 or 3 marathons now, and she's like, I want to say like under a minute from Olympic qualifying time, but it's because like it's rained every time, or like one time it was like 102 degrees outside. But she's gonna make it. She's gonna make it this year.
Are her times as good as they were when she wasn't paying attention to the running gait, or are they better?
So, she's faster. She's faster now that she's not thinking about it. And the way we got her to not think about it was, I'm like, okay, how much strong, and like, I had foresight on this. I knew this was gonna be a problem for her, because the first time she came in, she was like, my knee bow's in, and I'm done. My running career's over. I'm like, you're 20-something years old, man. Come on. So we took a video of her doing basic movements: single leg deadlift, squat. We took slow motion camera of her running. We took slow motion camera of her single leg and double leg jumping. Back pocket those things, and like down the road, like she did rehab. She was 100% good. She now works with our strength and conditioning guys over at our clinic. She's feeling great, and I'm but she's still kind of like worried about this knee bending thing. And I'm like, how do you feel right now? She's like, I feel great. I'm running faster than I've ever ran. Do you feel strong? I feel 100% strong. How's your knee feel? My knee feels great. How's your heel? She had a heel problem. How's your heel feel? Heel feel awesome. I feel 100% great. If it makes you feel any better, let's take a look at those tests that we did again. And we shoot video of him again, and it's the exact same thing.
Crazy. Because, those videos you want to instill change, right? Like, look at the way your knee's buckling.
Yeah.
It happened again.
Yeah.
There it is.
Just the same amount of angle.
Yeah. We're standing there, and she's like, it looks the same. And I'm like, wow, I didn't see that one coming. Wow. But, like, I'm not going to train her to run like someone else.
Right.
She has been running since she could run. And like so who am I to try to take, even if let's say I saw her once a week for a year. Yeah. Who am I to try to change something she's been doing for 20 something years in 1 year? Like that, it makes in 5% of the amount of time that she's been doing it for the entirety of. You can't do it.
Coach, strength and conditioning coaches talk about this a lot. Like, what kind of gains are you going to get from really pulling someone out of their quote strengths and working on their weaknesses versus just mitigating their faults or whatever you want to call them, so they don't turn into, or they don't snowball into something else, and keep focusing on their strengths. So like something like this, it could just be her anatomy, her neural patterns. She's very comfortable with it. When she starts to really push herself, she falls into these things that it's not necessarily bad. It's just she could do strength conditioning exercises to kind of mitigate the losses or the imbalances that could over time at a cellular level break down, but not necessarily. I feel like that's like the hardest thing to, especially if someone's emotional and attached to the sport. If you try to talk to them logical, like, this is what we could do. I'm not going to give you a blanket, A does not equal whatever. So I feel like that's really hard.
Definitely hard, especially as Matt said, this is a pattern that's been there forever. And who are you?
Ever since she could crawl.
Right. And she's been crawling.
All that knee valgus crawling around.
It's so wild. A lot of patients expect that knee valgus or that lordosis to kind of like, I'm looking to correct this, or I'm looking to fix this. And it's what you've been given. It's all right.
Mm-hmm.
But it's also like, and maybe you guys can speak to this. It was actually in one of these articles. To tap back to one of these, but they talk about one of the leading roles of burnout being autonomy, and like what you say goes, right? So, for this girl, or like, if you look at the pro athlete, and the pro athlete, by the time they get to me or a member of my team, we're kind of like, all else has failed. What can you guys do for me? And luckily we get them before like bad stuff happens to them. Like, it totally just falls off the wheels. But with these everyday people, like, I mean, obviously I have less autonomy than you guys do as a PTA, but a lot has been said to them, and we talked about this already, and a lot has already been done to make up their mind. And I think the only way to fix that, and I face this burnout right now, like, full disclosure, I am 100% have on my mind whether or not to get out of PT. And it's just this idea that, like, no matter how smart I am, no matter how much I read, no matter how many con eds I take, no matter what I know, my patient will always come in with a preconceived notion that what I'm about to tell them is not wholeheartedly the truth, or what I'm about to tell them is not as right as the answer they previously got from some guy who's got 2 different letters after his name than we do.
Correct.
And like that, or girl, either way. But that becomes a problem for me, and that. So when a pro athlete comes in and they're like, team doctor said, he's got real bad plantar fasciitis, and I'm like, okay, I mean,
real bad.
From what, like choking on steak? But like, no, like, come on, or like, I'll have like
nerve damage.
I'll have 15-year-old kid come in, low back pain. Hey man, my doctor said it's from I've been
wearing my backpack.
Oh my god!
Sorry,
you don't want to. I would.
Studying.
Oh man, okay. I'm gonna lose it on that. But no, there's like, he's like, my doctor says from jumping up and down playing basketball, and I'm like, how long have you been playing basketball for? He's like, oh man, since I was a kid. I'm like, you're still a kid.
You're 15 years old.
I'm like, how long?
It's been 3 years.
He's like, yeah, man, my parents put me in basketball when I was 5, and I've been playing ever since. And I'm like, you ever have low back pain? No. And I'm like, it's probably not basketball.
Right.
Yeah.
Like, but do you hate where you go to school, buddy?
Do you have any friends?
Do you have any friends? Like, no,
do
but like,
you eat lunch?
like, like, what else are you doing differently? That sort of thing. And like,
Right.
it's he like, we talk about it, and he finds like, oh man, there are maybe these couple things in my life that I need to do differently, and he makes those changes. He never misses a beat on basketball. But now I've got his buy-in. He knows that we can help him, and so now, like, even from a business perspective, he is now so bought in. He's like, I want to participate in the strength conditioning stuff you guys offer, even if it's out of pocket. I mean, it's his parents' money, so it doesn't bother him any, but but that's the sort of thing. And so, I don't know, I mean, when I look at everything that, tying this back to buyout, when I look at everything that I'm doing as a clinician, when I'm looking at everything that our field is doing compared to other fields, when I look at, I think I brought one with me. You guys don't keep researching your backpacks at all, or?
Oh yeah, I got it.
Sure.
But right here.
OCS equipment right here.
So this one, there's one for like necks, shoulders, knees, whatever you want. But this is for acute low back pain associations with subsequent healthcare costs.
Oh yeah, I think you showed this to me.
And so like it is.
Let me take a look at that.
Here you go. Mate. It is just here's another one that shows direct access is cheaper than any other way to treat any kind of anything.
Just spoke to that. We spoke to that.
But it's essentially like if the service I offer is cheaper, it can be just as accurate, right? And I don't want to pay for that article in the print.
No.
Yeah,
that's
you get
cool.
just the abstract.
I just go right here.
But if what I'm doing is just as effective, it's cheaper for not only people but health insurance companies too. So they should be 100% on board for this, right? And and the research shows it gets people better. Why are you not listening to me? Why is everyone not like? Why am I not the guy that everyone turns to in the office? Because you get an orthopedic perspective, you get a neurological perspective. For cardiac specialists out there, you provide the cardiac specialty to it. There is a specialty now like OCS, SCS for almost every field now in PT, right? Mm-hmm. And on top of that, we spend more time with the patient than anyone else. So when you're in a post-op ACL, and I have seen you for like 25 visits by now, and you go back to the doctor because he's canceled on you 4 times. Talk to me. Like, shoot me an email. Be like, hey, man, I know you've been seeing this guy. Not like, you need to work on flexion. Like, no, man. Like,
the 2-minute appointment.
Yeah, like, this is not, you need to talk to them about it. And, like, again, I think this is a big portion of this burnout. And I know this is something we want to talk about, but, like, I think I can't generalize for all the young therapists out there, but, like, this is something that's hitting me hard right now. And realizing that, like, if I'm in the midst of making the consideration to do either DPT or MDDO, and in making this decision, like, I want to be able to help people, and I can't help people if other people are unhelping them faster than I can help them.
Speaking over you almost, and it's not over you. It's just like you said, the patient's perspective is, well, this is definitely the expert. This is this is the MD, and this is how it's going to go. And it's almost like white noise what you're telling them. Yeah. But I think going back to what we were discussing about the relationship and this person buying into your knowledge, and I've been successful in that. I don't want to say talking over the doctor, but giving the other side and saying, hey, I'm not saying that that's necessarily wrong or right. Hear me out. This is what the research shows. Let's see how it goes. Let's just take it day by day, or let's give it some time. And I have encountered that, and I usually write it all. I think I don't take it as personal. I used to take it personally, but I think now it's like, okay, some people will listen, some people will pass you over, and for those that pass you over, I'm not going to just totally disregard them. I'll change my delivery method. And change it again. But, some people unfortunately, we're not going to be able to help them all because of those barriers. But I see what you're saying, though. I mean, if you were that initial person of contact, and that also goes to PTs in general. I say as an industry in general, a lot of us went to school, again, well-intentioned, but often don't have the marketing skills, don't have the communication skills, don't have... And some just this innate connectivity to say, how the hell am I going to get this message? It sucks to say this, but almost like there has to be a little bit of a salesmanship in there. And I think we've discussed this about fitness, and you probably witnessed this with a lot of trainers. They're great at it because some trainers may be telling their patients that they actually have 3 arms. And they may believe it because they have that much buy-in to this person. And not to knock any trainers to tell their patients they have 3 arms, but it's just the salesmanship that is something I think that the PT as a practice needs to work on. And again, it's the allied health thing, right? It's the kind of satellite, oh, well, PT is just like one of a few other things that are kind of helping out this medical model of ours, you know. So hopefully we could change that, right? Us in this room, actually.
Yeah, I mean, I have a lot to say because you mentioned you're even considering not continuing with physical therapy. So, like, 100% disclosure is I've had this conversation to myself probably like a dozen times, and I've involved Eric in it a bunch of those times, and Eric can definitely speak to the amount of times I said, I'm out, I'm done, I'm not gonna do this anymore. This is ridiculous. I got too much money I owe, and this is not making any money. But I think that's completely normal. In the United States, I think it's 100% normal for every physical therapist who is trying to do their best to go through that at least a couple of times. That's one. I also do think that if you were to look 15 years ago at our profession, these conversations about patient interaction and what we can do without insurance, things like that, they weren't even being done. So in terms of the progress that we've made, it's taken a long time for conservative management to get this far, and I think it's been a huge confluence of things. I like to use the line, there's a storm coming, Mr. Wayne, and you all better batten down the hatches and prepare for it, because it's this combination of the opioid epidemic, this influence from other countries showing that surgeries aren't as effective as they thought they were, and then you have the implementation of neuroscience, and then you have more people saying there's a psychological component, and you have all this evidence is kind of overflowing. And now people are trying to decipher it and figure out what to do, and it's on the front page. It's still being combated with like mainstream media. Like I had posted on my Instagram this individual doing some idiotic stuff with the backpack and talking to kids and stuff like that. Like that stuff's gonna still happen, but on a whole, I think it's not gonna stop. Our progress is not gonna stop in the sense that. We're going to get more autonomous. We're going to get more attention with the patient, and then it will finally hit where it'll be more value on us with, let's say, the insurance companies. But I do think it does take the groups now who are coming right out of school. I've mentioned his name so many times before, Zach Gabor. He's probably the reason why I mentioned him is because he's the most noticeable right now, at least for me on social media. He's taking initiative, and he's trying to kind of recruit people to push this idea forward to make a change, and giving them a way to do it, a method to do it. And I think that's key. I think there's going to be more and more people like that. And I talked to a lot of new grads who are already not working in clinics where they're accepting insurance. So stuff like that I think is going to be key. I don't know if you wanted to.
Where do I chime in? There was tons of good commentary there. I guess I had advice for you. You know, I've been in that boat before, just like Lee has, and I'm excited. I'm excited about the future. You know, there's a lot of things that just flat out suck about where we are as a profession right now, and we've talked about those things. But man, the potential there, it's like our floor is here and our ceiling is so high, and you know, I'm driven by that, you know, motive alone. You know, I do understand all these barriers to getting there, but you know, like I said, I'm all in right now. You know, I see a bunch of like-minded people, and I see, you know, I enjoy the relationships I'm creating with those people. So I'm able to combat all of the, you know, the lack of autonomy and the demands with, you know, that mindset.
Yeah.
Yeah, I mean, I guess I get it. Like, I don't know.
This is not like I'm not just saying to say. I think you're an extremely talented individual who has. You see things, you know, before you even finished up school that I don't even think seasoned therapists could see.
Right.
And the way you communicate with people, that's rare.
But I get it, though. You also want to feel – I get his point, and you put all this time and money and effort, and you want to be rewarded. The way I see it is kind of creating your own – we're talking about a system, right? And, you know, you don't have to be part of it. I mean, as you know, in treating the individuals you treat, you could create your own niche and basically make your own rules and create. I mean, going back to jiu-jitsu and listening to one of our instructors talking about, you got to create your own path, and if you don't see that path, you'll never take it. But yeah, there's all these barriers and there's all this stuff and yada, yada, yada. Yes, but ultimately you will come to a point where you pretty much want to work with the people you want to work with. And typically those people will listen, and, these barriers will disappear,
I mean, like, I hear the word you're saying.
Yeah.
But, like, I mean, there was the thing Eric sent to us the other day about the APTA lobbying.
Oh, yeah.
Yeah.
We didn't even get into that.
Yeah, no. It was like a rib. It was like a rib shot. That didn't feel great.
Seriously.
And there was a back. Did you see?
I couldn't finish.
I didn't send it to
couldn't
you,
continue
man.
reading after.
There's
like,
a follow up
the
on
fourth
that.
one.
There's just another rib. It's like a uppercut. So there was a.
Well, so just
I'll
to
let
quickly,
you guys.
I don't know where you're going to highlight about it, but there has to be another stronger, representation of us, and I think that's what's happening individually, and I think how things go. It seems that people usually get together to make stuff like this, and the fact that their speed is like slower than a sloth. They'll just continue to be left behind, and then there's going to be other people pushing for a strength and conditioning elective at a university, and there's going to be someone pushing for more direct access, and da 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 da. So it's like, I feel like it'll come together.
Yeah. So I mean, I was having this chat with another young therapist that was listening to the insurance, and I was telling him, hey, I sent him the article, and I said, this is part of the reason, part of the reasons, that the lobbying power is poor. And he said, it's a vicious cycle. A lot of PTs don't pay their dues, so the organization don't have the resources to do what they do. And the people at the top of the food chain at these organizations are very old school, and they're playing politics to the large mills, so they're not fighting for the little guys, or I don't know. It's a complicated political thing, but there was a follow-up to that article, and it was as sad as the initial thing. And it's just leverage, man. There's no leverage. And I think, again, it's part of the mindset of the average therapist that wants to help and wants to play nice and doesn't have that business savviness or that kind of, like, I don't want to say killer instinct, but instinct to say, wait a minute, 90-10, what's going on here? Why is it 80-20? Why can't we push? But I think that'll change. I think with the new generation, as Lee mentioned, are leveraging social media in a big way, and also very idealistic. Well, have a certain ideal on what they want to put out to the world, like yourself, like what you just said. Like, hey, I really want to do the right thing, but I'm just running into this wall. But walls are meant to be taken down, so.
Yeah. I guess just like when the governing body that like helps you to push this stuff is just not they're non-existent. Like it's just not there. I don't know. It's hard to say. Whereas like if you look at like the American Medical Association,
Poof.
I mean like I could get a drug pass in a week. Like
That's true.
You're right.
you know what I mean?
Yeah.
And so I don't know. I guess if you look at it, the evidence is there. Like cost of care is lower if you see a PT first. So if cost of care is overall lower, then an insurance company could theoretically increase the reimbursement and still save money. So you could make it so we don't have to. I wouldn't have to go out of network. I would be happy to take your contracted rate if it allowed me to keep the lights on.
Right.
Well, this is unfortunately, as we know, a certain organization, how things change. Right. It really starts with one person in a position as an influencer, aka an investor, an executive. Someone that has both economic and political pull. If you do the right thing by this person and show them what it can be, because maybe this person has had a different experience, and you're the first person to change their perspective. I believe that's how it's happened. I mean, as we've discussed without discussing, that's how it happened, right? And this large institution. That was run by an individual, was treated by an individual that was well-intentioned, and that individual said, I admire what you did. You just avoided me getting X surgery. What's your idea? I'm going to back you. And
With a lot of money.
with a lot of money that continues to be burned. No, anyway.
No, but it's true. It's like the right person at the right time.
Yep, right. And that, I think, comes from consistency. And it's the demographic we're talking about, right? Even with all the resources in the world, they've some of them had shitty care, unfortunately. And, it's like, wait a minute, where's your machine? Where's your ultrasound? Wait a minute.
And we're not talking about this for people who might be listening. It might sound like we're very flaky and we're like throwing up all chips in the air. I hope it lands over there. No, I mean that's why we knew we knew what we could offer in a setting like this. That's why we started the podcast, so we can offer the pieces of information at a time. And then Zach Gabor, for instance, he did hardcore. He can offer it like a system at a time, and he's reaching out countrywide. And you have other people kind of doing the same thing. So I feel like everyone is utilizing those tools in their own little way. They know what they're doing in that sense. So it's leading to this, confluence of collaboration that's going to affect a change. But I think eventually there's going to be a conversation had regarding this association and some actions that need to be taken, because even if every physical therapist were to give their dues, then what are they going to do? They're going to do the same thing. They're not limited by the fact that they're lacking the dues. They're limited by that mindset. Like the person said to you, it's an old mindset.
Old mindset, old school mindset, and trying to do the same thing under a completely different environment.
Right.
I mean, even in 8 years, the environment's changed. I mean, 4 years, the environment's changed.
What did you say about the model?
I forgot. I must have said it 1,000.
Forgot it.
Wait.
The old model is dead.
The old model is dead. I said it 1,000 times. And then when I left the old model, I was like, oh, shit. What about this new model? I got to do this all. Yeah, so.
But it's so much better in this. I know right now it's only limited to certain groups of people, but like the situation, at least I'm having, is extreme. It's extremely satisfying because you're getting time with the patient, you're getting that buy-in with the patient because it's a different scenario for them financially.
Right.
They're going to be thinking about it very differently when they're in there with you, and they're also usually in a certain position where they've kind of gone through the other part, and they're like, "This is not valuable."
But a lot of patients I've dealt with recently have been through. They're like, "This is the last line." One of a referral source that I have is often like the last person, this is the last person. And a lot of them are very resistant to what I have to say or what I'm going to do. And if they're referred by this particular person, they do put a lot of stock in me, but there's a lot of skepticism. And they're like, well, why, where's this and where's that? And why aren't we doing this? And is this, and it takes a lot, it takes a lot. But it's like, it's the science and the art. And I think it's a little less science and a little more art, in my opinion. Any other comments?
If you guys, if you had anything to say, let us know. Or we have 5 questions we'd like to ask each of you guys.
We'll
yeah.
alternate who we're going to start with first. So.
Should we alternate?
Well, I think they could group because they'll give one of them a little more time to think. But go ahead.
Okay. Yeah, so whoever gets it,
it's going to catch him off guard.
We weren't sent these ahead of time, right?
No, yeah, we didn't send them.
No.
Okay.
This is this guy Lee's idea. He wants to squeeze you guys here.
Oh no!
I love a good squeeze.
Are you familiar with Inside the Actor's Studio with James Lipton? No.
Is this like an older
Tim
people
Ferriss,
thing?
man.
Oh
What
my
about
God.
Tim Ferriss. No, Tim Ferriss has random. He has.
Random. Anyway, regardless, look it up after the show.
Okay.
I'm gonna start with Jordan. What's your favorite anatomical term?
I usually defer to quadratus lumborum.
Nice.
All right.
Just sounds
Cool.
like a Harry Potter spell of some sorts, and patients like to hear
Quadratus
anatomical
lumborum.
stuff.
Nice.
Nice little Latin. And
Same
yourself,
question for you, Matt.
Duodenum.
Matt?
I think I lost.
That was like
Duodenum.
that was also my favorite. And then Jordan, what athlete inspires you most? It could either be like the sport of the athlete or the actual athlete.
Ooh. Well, growing up, it was always Derek Jeter for me.
There you go.
Derek Jeter is the full personification of what it means to be a great athlete, but also a great person.
Yeah.
Unless there's some scandalous stuff that comes out about Derek Jeter in 5 years.
Wow.
He has been a model citizen, a model, New York Yankee, which is a team that I support. And, growing up, everyone was trying to emulate his iconic throw from the other side of the diamond. So I got to go with Derek Jeter.
Good choice.
He's a cool dude, yeah.
Mr. Laliberte.
Let me think. Specific athlete. I think it would have to be my childhood hero. So I played baseball growing up. Actually, just got hit for something. So it can't be him.
Oh no!
Everybody's getting hit these days.
Yeah,
though, it's tough.
it can't be him.
Oh man.
I mean,
Yeah,
I would say. Okay, I got one. You guys are gonna think it's ridiculous, but I'm wholeheartedly serious about it. So let me explain it. The U.S. men's Olympic curling team.
Well,
So
definitely ridiculous. All right. Cool.
okay, hold on. So I'm actually really big into curling. Like
right.
I think this is a pretty awesome sport. It's much harder to do than it looks. Like when I looked at it, I was like, I can use a broom and I can stand on ice, so I could do this. We have a running joke that we're actually a few of the trainers at my office. We're going to try out for the U.S. men's Olympic curling team.
Dude.
We have found out it is significantly harder than it looks.
Yeah.
I'm sure it's
There's a lot of knee valgus in there.
A lot.
Go. And they blow on the stuff.
I gave it a shot. Like, I don't know, I want to say like 6 months ago or something like that. And I woke up the next morning, my shoulders hurt from sweeping so hard.
Wow.
Oh,
Dude, that's awesome.
So a lot of respect to those guys, because they if you look at them, they don't look like elite athletes, but they're slinging it, man. That stone is heavy, like it's real. So
the guy got emotional recently. I remember him getting interviewed.
Yeah.
U.S. Olympic curler, yeah.
But I mean, like during the Olympics, I'm out of my chair, I'm off the couch, I'm yelling, I'm throwing stuff.
That's great.
I'm like, come on, like you got to get past the hog line, buddy. Let's go.
I got to learn the ins and outs of it because that's one thing.
I just see the stone, the broom, and then people screaming.
Yep.
Yeah.
It's nuts.
Very
hilarious.
intense. Yeah, that's cool, man.
I love it. Next question, and I'm glad you two are here. Pickle Rick, Tiny Rick, or don't know?
What's in the syringe, Beth?
I actually think I was talking to you the other day about Pickle Rick and how I just, that was one of my favorite episodes. So I'm going to put all my chips on Pickle Rick.
Nice. Mr. Liberty.
I listened to a lot of emo music growing up. So in the Tiny Rick episode where he's like, I know, that was a bad phase. Just like in general, it was a bad phase. A lot of skate shoes. I've never been on a skateboard in my life. But in like Tiny Rick, he's like, I'm not okay. This is not a song.
I'm really hurting inside. Or some shit.
Like I'm dying on the inside. That's not a metaphor. So yeah, I'm gonna have to go with Tiny Rick. I'm Tiny Rick.
That's awesome, man. Did you hear about the Emmy?
No.
Yes.
They got the Emmy for Pickle Rick. It was like the best. You gotta look that up. It was awesome.
Yeah.
I was like so psyched.
Oh my god.
I reposted that. I was like, this dude's killing it. I love it. Oh man. Okay. Let's see. Next one. If you were to meet yourself 15 years ago, what advice would you give yourself?
Loaded.
Yeah.
Originally I was going to say don't go into physical therapy, but I'm holding back because I'm still happy with where I'm at in my life as a whole, and what I'm able to do with my patients. So I wouldn't say that, but I think I would tell myself, to trust the process a little bit, enjoy what life has to offer. Like I said, with patients, things don't manifest in a day, and neither is the case with life. Like I want to be even more successful and, getting more patients better, sooner. But, my path is just a little bit different than everyone else's path. And just because I'm not there right now doesn't mean I'm necessarily a failure. So, just trying to keep that mindset and keep on the path that I'm going. I think I'm pretty sure that one day it's going to bear some success for myself.
Nice.
Nice, man.
That's a big one. I'd like... This is actually something I thought about. I think I would. Oh man, it's hard. It's like 50-50 between like giving myself the advice to just not go into medicine at all, or get into it as soon as you can. Like, in undergrad, like I had this thing where I really didn't know if I wanted to get into medicine or not, even though I'd wanted to do it my whole life. And I kind of went back and forth, and obviously we're here, so I did it. But I think I would tell myself, like, don't second guess it, just go 100% into it, because like the moments where you do feel like you're doing something, it's the 5% of the time that you feel incredible about it, the other 95% doesn't exist. Like, it's
correct.
Yeah. So I guess I would tell my what would I be, 12-year-old self.
You're like, what? Who the fuck are you?
I would say stay away from the cookies. And I was a chubby kid, and getting
Eat farm to table.
Go home.
Eat organic. Eat organic.
You start that trend early.
That's right. Buy stock on Amazon.
Yeah.
What's Amazon? Oh shit! All right, last question. What's your best athletic achievement?
First thing that comes to mind is 11-year-old All-Star Little League MVP.
There you
Nice.
go. Hey.
Yeah, I kind of crushed it. I almost hit a home run that game. I got the MVP.
Sweet.
Man, and again, I had like B cups at the time because I
What?
was also a chubby kid.
I'm like, B cups. What?
Yeah, wait.
Oh, I should have prefaced it with the fact that I was a pretty chubby kid. Yeah.
Same here, brother.
Let's see. You guys know who Zach Wheeler is?
Yes.
That was a hard yes by Jordan.
I'm fanboying so hard.
That's fair. I hit a foul ball off him, like in a baseball game.
Who's Zach Wheeler?
He pitches for the Mets now.
Yeah.
Oh, wow. Look at this. That's crazy.
Jesus.
But this was back in the day. So there's like this like Premier League kind of thing that you play in back in Rhode Island. It's like a big Northeast thing. It's called American Legion.
Mm-hmm.
And he had pitched. At the time, I had no idea who he was. And I think he threw like an 18 strikeout game or something. It was just not right.
That's crazy.
But I hit a foul ball. If it was fair, it was gone. Like,
That's awesome.
And by that, I mean I drove that thing so hard into the ground. It was a full-blown tomahawk. But, yeah. So foul ball off of a kid who would, 10 years later be a professional major league pitcher. So,
Damn. That's cool, man.
yeah, wish I kept that ball. I actually have a ball in my room that's just from that game, but not that ball. But I pretend it's that ball. So.
Yeah. I would say it's that ball.
Yeah.
Who's going to know?
Yeah, no one will. I signed it myself and everything.
Very cool, man.
That's awesome.
Well, we're going to be wrapping up shortly, but if there's anything we didn't cover, we could probably go on for another
Hour and a half.
hour and a half. But I know that we went tangential as we normally do. But Jordan, anything you want to, any closing remarks?
Yes. First of all, awesome opportunity. I had a bunch of fun doing this, and it would be no different if we were at a bar somewhere having a couple of drinks.
Exactly.
We still talk shop, and that's what I really appreciate about this experience. But I'd say to the patients out there, or prospective patients, or anyone experiencing pain, first of all, if you're having trouble getting out of pain, and you think that the system has failed you for so long and no one's really addressed your problem, this is an avocation for physical therapy, but there's a lot of brilliant individuals that can really offer you a different perspective on your pain. Ultimately, just understand that when you're in pain, your tissues and your system just failed to adapt to the loads of whatever activities you're doing or whatever life stressors are placed on you, and we're going to help you, gradually get back to the things that you love to do. So, always keep physical therapy in the back of your mind. It shouldn't be in the back of your mind. It should be in the front of your mind, rather. But, yeah, we're capable of doing, some amazing things. And even in the short period of time that I've been practicing, it's been rewarding, and I'm just hungry for more.
Well said.
Cool.
Yes, I guess my turn.
Yeah.
Everyone turned and looked at me. Yes,
Matt.
You can do like a Ric Flair thing.
There's no bass left in these headphones after that.
Oh, that's hilarious.
So Yeah, so my second time on, so thank you guys so much for having me back. I wouldn't have had me back, so thank you so much.
We're going to have both of you guys back.
Yeah,
I mean,
dude. This is the number 1, so there's definitely going to be number 2.
Yeah, exactly. This is the square table discussion, not the round table. PTs. Well, we were actually thinking of changing the name of the podcast to PTs of the Square Table.
That's right.
Yeah, it's very cool. Thank you guys. Very insightful, and we're really lucky to have both of you. Thank you for your time, because you guys could be treating patients or drinking beer or whatever you want to do. But thank you guys for coming. Appreciate it.
Thank you guys.
Thanks.
You had anything else to say?
Nah, man. That's good. I mean, like, the only thing else I was gonna say was if you are a patient and you're deciding whether or not you are at a good PT place, because I've had a lot of people ask me, how do I know good PT right off the bat so I don't have to burn 10 visits? When you go for the eval, if you say something to the therapist and in the first 30 seconds he starts talking to you or cutting you off, respectfully leave. Because that is not the type of place where they're going to listen to you, where they're going to acknowledge what is going on and help you through it. Because they're just seeing you as a diagnosis. And we know this. There's been research on this. We know about the 20-second rule. We know about all this. So first, talk to them, and if you don't feel like you're being heard, you're not.
Very good. I think I'm going to put a plug for a book that I read in my first year of practice. Remember The Mindful Therapist?
Oh, yeah. I totally forgot about that. That's
just this kind of, I wanted to bring it up.
powerful.
I didn't want to cut. One of you guys was discussing it, and then I read a book. I was recommended a book by a course that I was taking. They wanted us to read this before we got to the course. It was called A Mindful Therapist by Dan Siegel, and he's a neurobiologist. So he's a psychiatrist by trade, but anyway, The Mindful Therapist, and what's in there is the therapeutic relationship and how what Matt just mentioned, the ability to actively listen to a patient and developing that rapport is paramount to anything. And it ties right into pain science. I mean, this particular individual, Dan Siegel, doesn't go into pain science, but he talks about the therapeutic relationship. And it has been probably one of the top 5 books that I've read that's changed the way I practice as an early therapist. So The Mindful Therapist, Dan Siegel,
God,
great
I totally
book.
forgot about that book.
Good stuff. It ties right into what Matt's comment right now of having a PT or a healthcare provider not listen to you. I mean, it's horrible. But there are a lot of great therapists out there that will listen to you.
It's true.
And look us up.
Yeah. Well, thank you guys. It's awesome. We're definitely going to do this again. For all your listeners out there, if you haven't already, subscribe to our YouTube channel, which we're going to be posting more videos on. Check us out on Facebook, Twitter, and obviously Instagram. But thank you guys again. It was a blast.
Signing off.
Signing off.
Thank you for listening to A Few Good Physios. Follow us on Instagram, Twitter, YouTube, and Facebook. Follow us each week while we interview guests and have clinical commentary.